April 13th in the afternoon, just about 2:30 in the afternoon on a beautiful April day in the year 2021. We are live streaming, broadcasting spine surgery here at Deuk Spine Institute. And this next patient has, unfortunately, 4 bad discs in her back. We're going to be fixing only one today. And that one is going to be the L2-3 on the right side. And she has not just a herniated disc, but a disc that has herniated out and pushed upwards. We call it an extruded disc. And the extruded disc has moved up towards her head in her spinal canal in front of the nerve roots. We call that a migrated disc herniation, because the herniation, the size of a grape, has pushed out and moved up towards her head. When a disc herniation does that, it's no longer located at the bottom of the foramen. It's now moved to the top of the foramen. And we're going to do our very best to get this thing out endoscopically. There's always a chance we can't get it all out, but we're going to try. That's what the patient wanted to do. Are you there? Okay, it's Dr. Deuk. That's my hand on your back. We're going to get started. I need you awake for the beginning to help me, okay? And then once we get where we need to be, I'm going to put you to sleep. So hopefully this will go smoothly in the beginning, and I'll keep you appraised, okay? In the meantime, I'll be talking to my team and talking to our viewers that are watching the surgery. Okay. Any questions for me? No. All right, I want you to be comfortable. Is your body comfortable where you are? Yes. Very good. And is your neck comfortable? Yes. All right. So the patient has some scoliosis, which does happen as spines degenerate over time. The discs collapse, the facet joints collapse, and the spine can start twisting as it settles. So we're going to go ahead and want to approach the right side L2-3 from the bottom, a little bit lower, and aim up. All right, I'm going to give you some numbing medicine, okay? You might feel a little stick and burn. Don't get upset, okay? Just bear with me. A little stick and burn. I'm sorry. Yeah, I know. I know. It'll get better. Just give it a second. It's kind of like going to the dentist, unfortunately. Is that easing up a little? All right. So just bear with me. Yeah, I know. I numbed up a pretty good sized area. Hopefully we won't need to numb anymore. I used 8 cc's. All right, so this is a really challenging one, and I'm going to see if we can access the disc a little lower and then come from below and aim up. All right, so let's see what we need to do here. Shot. So 5-1, 4-5, 3-4, 2-3. Probably need to be a little bit lower. Shot. Let's go with a lateral view. All right, so 5-1, 4-5, 3-4, 2-3. By the way, beautiful, beautiful X-ray job. Okay, nice work. I don't really trust the needle. Can we get another one? You comfortable? I'm going to just throw this off the field. We have a sharp on the floor. All right, so shot. I'm sorry. Incredible. I'm going to start a little bit lower. I'm just pushing on your back. That's just me. Don't worry. You're just relax. It's important that you don't move. If you feel pain, just say ouch, okay? Thank you. All right, so I want to infiltrate a little more. I want to have a little bit lower starting point than where we're at. All right, I just did another CC. Huh? Everything okay? Shot? That's a nice lineup. May even want to come a little bit lower on my entry. I'll give you some more numbing medicine. Shot. That's pretty good. Shot. All right. So we've just put some more of the numbing medicine to make the patient more comfortable. Give it a minute to work, and let me see what we've got here. I think you're lined up nicely, Jordan. I think everything is looking good. Shot. My key is to come lateral. Shot. Let's get an AP. How she's interesting. She's got really big foramen. So we're not used to seeing this in our patients because most of our patients that we operate on, they do have herniated discs. We call that acquired. But it's really unusual actually to see such a big neuroforamen. All right, so that's our AP, and our lateral is there. I think we could be a bit more medial. I'm going to start a little bit more medial. Shot. And let's go with a lateral view. Actually, right there. Take a shot, and then let's go with a lateral view. You're doing great. Just lay down. Keep your head down. And are you comfortable? Okay. So getting everything lined up properly is important. And that's my lateral. And where's my AP right there? Okay. Really like to dock on the facet joint. Shot. Shot. AP. Yeah, that's pretty good. That is pretty good. And let's go back to a lateral. So you can see those circles above and below the needle. Those circles represent the pedicles or bones coming off the back of the vertebral bodies. Are you comfortable? Your nose is itching. Okay. Well. You can scratch it if you want to. Does propofol make noses itch, or is that the fentanyl? All right. Shot. She said what? She hasn't had any propofol, just fentanyl. How's that? Do you feel any discomfort there? Where? In your back or in your leg? Give me an AP. It feels like the herniation right there. So I feel like I'm touching against the herniation at L2-3. At the bottom you see 5, 4, 3, 2. We're at 2, 3. And we're just underneath the exiting root. Yeah. Just underneath the exiting root. And this is where the herniation is. Okay. You feel anything there? Yeah. All right, let's go back to a lateral view. The AP looks okay. Where? In your back? All right. Shot. Try to relax a little. You're doing really good. Do you get much back pain? Or is it all leg? Huh? No, but normally do you get much back pain, or is it more in your leg? How bad is that on a scale of 1 to 10? What's the highest it went up to? 10? All right. All right. So the good news is we're in the bad disc, the one that is has the herniation going out and up in front of the nerve root. So when you're done, when you wake up, that pain you felt now will be gone. But I'm also going to try to fish out as much of the herniation as I can. All right, so you get to go to sleep now. You did your part. Concordant. Yeah, is that where you typically get back pain? Yeah. All right, so for those of you watching, you can count from 1 to 100 out loud. And when you wake up, we should be done with your surgery. Just lay still. Count out loud. So, folks, we are in the L2-3 disc. You can count the bones from the bottom at L5. You see the sacrum, then a gap, then L5, 4, 3, 2. So we're at L2-3, this correct level, correct? Yes, sir. We're on the right side, we're on the correct side. And we know from the MRI, she's got 4 bad discs, but this is the worst. And this one is massively extruded. Now, whenever I talk to my patients about getting back surgery done, I never guarantee them I can do the surgery. They all know there's a chance that I won't be able to do the surgery once I get in here for anatomical considerations. This would be one of those cases. Is that my lateral view? All right. And the reason for that is, sure, we're in the disc, and sure, we can fix her back pain, not a problem. But what I'm concerned about is this piece of the disc herniation that went out and up. And it literally went up behind the vertebral body. And I'll show you what I'm talking about in a moment. What am I doing with this? I'm going to use that on you. Did everybody get some lunch? Did everyone eat? Everyone but Luis? Luis, are you kidding me? Thank you. That's all right. Luis probably is on like a Red Bull or a Monster energy drink or something. He's on that 5-hour energy drink. All right, so we just made our incision in the flank, and now we're going to go in transforaminal. This is L2-3. Okay, shot. So I'm going to do everything like I always do. For some reason, I'm not, we got to see up there better. You're like showing me the sacrum and all that. I don't need to see all that. I need to see L2-3 really nicely and get those pedicles lined up beautifully. What I was getting at earlier, folks, is that the foramen here is huge. It's much bigger than what we normally see. Everything okay, doctor? Yeah. Yeah. So the neuroforamen is the hole where the nerve comes out, and her neuroforamen are like literally that big. And for a lot of patients that we end up doing surgery on, they have a narrow foramen because they have a short pedicle. And the fact is that her pedicles are not short at L2 or L3. So she has a really wide foramen, but the problem is she has a tear that's causing her back pain in the back of the disc, and she has also an extruded disc that has really moved up, unfortunately, moved up, shot behind her pedicle. Okay, and that's what I'm worried about, trying to get that guy out. So we're not going to start trying to get him out, but we're going to end trying to get him out. Shot. Okay, so at this point, let me advance this with the mallet. Shot. Shot. Yeah. Not done. Take that. All right, so shot. Good. So at this point, we're in the disc, and we're going to do our annular repair and our debridement, basically the annular debridement, which is the hallmark of the surgery. And then we're going to, as we come out, and we're taking out the disc herniation as well, I'm going to start looking north towards her head. I'm going to angle the scope up and see if I can grab a piece of that herniation that's moved upwards and try to pull it out. Okay? Shot. This is on a level of 1 to 10. This is a 10 surgery to do. Okay? And she knows that. I told her that before, that there's a chance I won't be able to get that fragment out. But she wanted to do it anyway. And it's the most reasonable surgery to try. The other option would be to do a laminectomy and try to fish it out around the nerve root. If we do a laminectomy, for sure, she's going to weaken her spine even more, and she will. I need the light for a second. And she will end up having a deformity, like it's worse over time. And so, if that's the case, she'll need a fusion. So by doing what we're doing now, I don't expect her to need a fusion. I think I can do this without fusing her. I think we're going to get this herniation out without removing bone from the back of her spine. That's the problem with laminectomies and microdiscectomies and everyone else's surgeries. Traditional spine surgery is the bone has to be removed in the back of the spine. All right, the blue indicates herniated disc that's degenerating. That's the nucleus pulposus that's degenerating. The nucleus does not degenerate unless it is acted on by inflammation. Of course, the center of the disc where the nucleus is, it has no blood supply. Naturally, no blood supply. Hence, there cannot be inflammation. Inflammation, by definition, must have a blood supply. The inflammatory process is mediated by capillaries and blood supply. You need inflammatory cells, which come from the blood supply. You need chemical messengers, which are released by the endothelium, and cells related to the blood supply. So this is where a lot of doctors get confused. They are taught that the disc has no blood supply. So how could it possibly have inflammation? What they don't understand, and this is a really interesting medical concept. Okay? And that is this. Oh, look at the herniation, guys.
Lights on, please.
Lights on. Look at the size of this thing. It's not going to be the whole one, but it's certainly going to be part of it. You all see this, Sean?
We are looking. Yes, we can.
Can you see it? Right there?
Yes.
All right, that's one of the pieces of herniation. So far, so good. All right, so let me tell you a little story. When I was in medical school, I was quite knowledgeable about the brain, neuroanatomy, neurophysiology. It was what I was drawn to naturally. And of course, prior to med school, I had no interest in it. Didn't even know about it. But once I got there, I was absolutely fascinated. I was just totally drawn to neurosurgery. So one of the things you learn early about the brain is that there is a blood-brain barrier, and that blood-brain barrier prevents certain types of cells or tissues or chemicals from entering the brain, the blood-brain barrier. Okay, it's famous in medicine. And one of the things that doesn't happen in the brain is you never get scarring inside the brain. You never get true scarring. Okay? Ask any neurosurgeon. They'll tell you this because they've been taught this. You know? Just like we're taught many things when we're young and in our beginning and our infancy, as humans we're taught certain truisms, okay? And you know, one of them is you don't play with a rattlesnake, you're going to get bitten. So what happens in the brain when there's an injury, like an ischemic injury, is you get a different kind of scar that you can't get anywhere else in the body. It's called a gliotic scar. And a gliotic scar is basically made up of astrocytes, which are supportive cells to the neurons. And when the neurons die, the astrocytes form this type of scar. But it's not really a scar, because a real scar has collagen, okay? And there is no collagen in the brain because there is no fibroblasts. And fibroblasts are the cells that make collagen. So with the blood-brain barrier, fibroblasts are not allowed into the brain. Only glial cells, which are your astrocytes and microglia and oligodendrocytes, they support the neurons. So you never get real scar tissue with collagen in the brain. That's what you're taught. So then I was doing brain surgery as a resident, and I came across a brain that I was doing surgery on, and it had scar tissue. Real live scar tissue. And it was shocking. It was a revelation. Nobody else really thought about it. Nobody else really seemed to care. But of course I said, how is it possible that we have scar tissue in this brain? Real collagen. And the residents that I worked with that were above me and were more knowledgeable at the time, they didn't know and they didn't really care. They were thinking more about finishing the surgery and going home to their whatever, golf game. Okay? But it perplexed me for days. Days turned into weeks. And finally I understood the mechanism. And the mechanism was simple. Where the blood-brain barrier becomes disrupted in those areas, which can happen with certain types of strokes and tumors or surgery, you can get an ingrowth into the brain of capillaries. And with those capillaries come granulation tissue. And with granulation tissue comes scar tissue. So I solved the puzzle nobody had ever talked about or solved before. Scar tissue. And it made perfect sense. And I had encountered this one other time in my training. When I was at UC San Diego, I was studying epilepsy in rabbit brains, and we used to get a scar tissue that would form on the surface of the brain. Now this was outside the arachnoid, and outside the pia and the arachnoid, but it was the same thing. It was scar tissue. And so I started to think about the disc, and how could the disc possibly get scar tissue inside of it, deep inside? And the answer became obvious. It's the same concept as the brain. There's an injury to the disc, and that injury is in the form of a tear, or what's called an avulsion, where the annular fibers are avulsed apart, and the scar tissue in the form of granulation tissue grows down along the tear and into the center of the disc. And that's how you get these discs like this one, where there's scar tissue deep in the disc. I wasn't the first person to describe scar tissue deep into the disc. No. There's a Swedish neuroanatomist who's dead now, I believe. And he used to publish papers on autopsies he would do on patients who he would slice up their spines and look at their discs after they died, of course. And he would show inflammation and granulation tissue growing into the disc. But nobody paid any attention to him except for a couple of us spine surgeons that actually cared about this stuff. But his work laid the foundation for our understanding today of how disc injuries such as annular tears cause back pain, neck pain, thoracic pain, all the spine pain you need to know. It's through inflammation. Inflammation that tracks along the injured tissue from the outside of the disc to the inside. And there you have it. Enlightenment. If you understand what I just said, then you understand more than 99% of spine neurosurgeons and orthopedic spine surgeons in the world. You understand the essence and origin of discogenic back pain and neck pain. All right. Do we have any questions from our audience?
Currently, we do not.
Currently, we don't. Thank you. So for those of you watching, you're watching a Deuk laser disc repair, endoscopic transforaminal spine surgery done at the L2-3 level for a herniated disc. And the primary purpose of the surgery is a debridement of the annular tear to get rid of back pain. If we're doing this in the neck, then it's to get rid of neck pain. If we're doing it in the thoracic, then it's to get rid of thoracic pain. This is the only surgery in the world done to eliminate pain. The only surgery done on a disc to eliminate pain, really. And I don't mean leg pain or arm pain, I mean axial pain, discogenic pain. You see, surgeons don't operate on patients to get rid of pain. Very few of us know how to do that. Most spine surgeons operate on patients to get rid of arm or leg symptoms like radiculopathy. But they don't know how to get rid of axial pain like back pain. They don't believe it can be treated surgically, but it can. This is the treatment. Took me years to discover it, but eventually I did, and I've been doing this surgery 16 years now. We've had 0 complications. Not a single patient has had a complication with this surgery. That's a remarkable record, over 1,000 surgeries done. and not a single spinal surgery complication with this procedure. It's the only surgery in the world done on the spine that doesn't have complications to date. So, why is that? Well, I am very careful about how I do the surgery. I know it looks simple, but it really isn't. There's actually a lot of planning and being careful that I'm entering in the right place and pointing in the right direction. This is not a surgery that a surgeon can learn how to do by watching me do it over the internet. This has to be a training process in person, and I'm happy to talk to anyone who wants to learn how to do the surgery. All right, we're at the back of the disc now. You see the end plate right there, the beige thing, and there's another one. We're literally at the back of the disc, and this is where the extruded disc has now gone through the annulus fibrosus tear, which is right back here, and it's migrated up towards the head, which is this direction, to the right. So we're going to follow this herniation up towards the head, okay? But I got to debulk it a little bit first. The blue thing, by the way, folks, is the laser fiber. And the laser fiber is coated with plastic. That's the blue color. And we have a technician here who is actually working on the laser with me. And the laser machine itself, oh yeah, this is the more stimulating part. She's starting to respond just a little. I probably need about 8 more minutes, maybe 10. So if you want to bolus her again or just increase her rate of propofol. Anyway, what I was saying is the laser, oh, there's a herniation. The laser itself is a machine, and it's about the size of, I don't know, 2 suitcases. It's big, and it would definitely fit on an airplane in an oversized baggage compartment. This laser machine generates energy in the form of what's called electromagnetic radiation. Standby laser. Electromagnetic radiation is a waveform of energy that moves through space and time in a wave-like fashion. Another example of electromagnetic radiation is light. Oh yeah, there's a nice piece of herniation. Light transmits or transfers itself. Photons of light, bursts or packets of light energy move in a wave-like fashion. Okay, so laser is not visible light, but it has a much higher frequency and a much smaller wavelength. But it moves as well through space and time in a wave-like fashion. So I'm using this laser energy to go in and ablate is the technical word for it. An ablation means to destroy, vaporize, break up tissues. So I'm doing an ablation with the laser. Take that. And the tissue I'm breaking up is abnormal tissue. Tissue that shouldn't be here. Tissue that's out of place and causing problems. And that tissue we call the annular tear and the herniated disc. So it's a combination of the herniated disc. Is the laser on? Yeah? All right. Now, in addition to the energy, wave energy delivered to the tissue that causes it to break up, we also deliver a sound wave which causes cavitation. And everyone knows that sound travels really good in water. That's why we have irrigation in here. Water. That's water that we're pumping in. ourselves into the operative field, the wound. And that water is not really water, it's sterile saline. And it's refrigerated. Oh, all the secrets are coming out. Why is it refrigerated? Well, cool the laser. Cool the laser, that's right. If we didn't cool this laser fiber, you would be seeing smoke. you would see a barbecue. And it's a very fast barbecue, indeed. It would vaporize everything quickly and very badly. It would char the tissue and vaporize it. All right. So you need to cool the irrigation. That's a trick I learned from Dr. Young. He taught me that. So I'm working on the herniation now behind the vertebral body. Remember I told you the disc herniation migrated? That's it right there. That's the migrated herniation. So I'm going to keep working on this and trying to free it up as much as possible. It really helps to come in. Let me have the grabber. It really helps to come in more laterally, a more lateral entry point in order to aim more medially. You know the trick with wiping this, right?
Yes.
What is it? Yeah, you got to push the material into the mouth to get it to come out. Okay? So we're doing something called debulking, and there's a piece of herniation. And when you debulk a herniation, you're basically taking out little pieces of it, a little bit at a time. Okay? And that's honestly the best we can do with this herniation. Because of the way we're approaching it is unique. It's through the foramen. So the blue stuff is the herniation mostly. Some of the white stuff is also mostly annulus fibrosis, but there is also some herniation in there. This would be a good time for a question if you have one. Laser. Does the audience have a question there, Sean?
We don't have any.
All right. What you're watching is pretty amazing because we're actually attacking this herniation in a way that most surgeons don't have any idea how to do this surgery. They don't do endoscopic transforaminal surgery. Most surgeons approach this kind of a herniation with an approach called a translaminar approach, where they go through the lamina by removing the lamina. And problem is when you start removing the lamina, you start to weaken the spine. We're not taking any lamina. Lamina is the bone. It's the bone of the spine. We're not taking any out. With this technique, we're preserving the strength and the integrity of the spine, of the natural spine, by not removing bone. Also, removing bone creates bleeding, and lots of it. Guess where blood is made? inside the bone. Okay, we call it bone marrow. It's the marrow of the bone. That's where red blood cells are made. That's where white blood cells are made. That's where platelets are made. Okay? They're all made in the bone. So by removing bone, you're destroying your body's ability to generate more blood. But of course, most surgeons don't know how to do the surgery without doing it. That is the tail of the herniation, folks, right there. Literally sitting under the nerve root. And we are zapping it away. I'll show you the nerve root in a little while. The nerve root is quite literally, it's the right L2 nerve root. And it's quite literally right here, where the tip of the laser is, just on the other side of that metal tube. The metal tube being the tubular retractor. And I'm just blasting away at the herniation. And notice all the little pieces coming out, right? They don't come out as one giant piece, they're coming out as little pieces. This is the end plate. So, trying to free it up, laser off. It's pretty remarkable. Yeah. I'm sorry? Yeah. Look at that. Oh, it's so cool. So, again, this is the part that's sitting under the root. And how much can I get out? That's the big question mark. Everybody's different. When you do these surgeries, you realize there's no 100% it's the same result every time. Now what the result that's consistent is, you know, physiologically the patients all do great with the surgery, but the anatomy is a little bit different in everybody. You understand what I'm saying? So the pain relief is the same. 100% is 100%. But the structural abnormalities are different in different people. Slightly different. I mean, they're not hugely different, but they're slightly different. So, here we are. I'm going to zap a little more with the laser. And then we're going to start looking a little more north. North is this side here, where the laser is. I need about 5 minutes, assuming everything goes well. So our first patient we did today, she's already gone. She's very happy. Her back pain for 22 years, 100% gone. And her left leg pain gone. And she's in disbelief, as are most people when they're done. The second patient also appears to have their pain gone. So they're both very, very happy, and both patients are already home. I've already left. All right. I'm literally taking this herniation out from the armpit of the nerve. Grab her. So the nerve root is running just outside that metal at about 2 o'clock. And this herniation here is sitting underneath the root. And I'm going in and pulling it out. There goes some more of it right there. That was really nice. I just love endoscopic surgery. It's just so elegant compared to open surgery. I've done how many years of open surgery, folks? 26 years of open back surgery and neck surgery. I've seen it all, done it all. And this is incredible technology. This is the future. And, you know, we've been doing it here for 16 years now. It's unfortunate that more doctors don't know how to do it, but they'll learn eventually. I have faith that they will. All right, just about done here. Take that for a second. Let's just take a peek. So the nerve root is going to be right here, right up here. And I bet you I can get, I'm just trying to work right in that corner there to get underneath it and get out as much of that herniation as I can. I think we've gotten quite a bit of it out. Any questions, Sean? We're going to wrap this up very soon. That's it right there. That's the herniation, folks, right there. That's amazing that we were able to get in here and get this done. I just can't believe it. It went better than I expected. Amazing.
There are still no questions at this time.
No questions. Okay. Everyone's as flabbergasted as I am, I'm sure. So just underneath the arm, in front of the nerve is literally running up here. The one that's going down to the next level, and the one that's coming out is a little higher, but I'm just literally right in front of the nerve, in the epidural space. And this, I'm working behind the vertebral body of L2 right here. You know, and I don't want to get too much into the body, but this is all herniation right here. So, looks like it's been there for a while. What a beautiful surgery. Just about done. There's a piece down below. Just want to make sure we get that guy. Yeah, this is a revolution. Revolution in spine surgery right here. Endoscopic. It's the future of spine surgery. You guys are watching it right here happen. And this is a very advanced technique right here, just so you know. This is not an easy endoscopic. I couldn't do this surgery probably for the first 5 years. Just because it's so complex to be able to do this. You have to really understand the anatomy. You have to be very familiar with all the landmarks where everything is so you don't make a mistake and hurt the patient. Just about done. Take it. Let's take a look. Okay. So there's the epidural space. That's where the herniation was in the axilla. And question is, what do I do with that guy? Looks like there's still some herniation lateral. Let's see if that's a loose fragment. Now if it's stuck down, I'm leaving it alone. Take it. Let me have the grabber. There's a piece of herniation. It was loose right around the back of the disc. And then let's pull this back a little bit again. And I was looking at that guy there. I don't know, that looks pretty solid. Yeah, let me have the laser. 2 minutes. Yeah. think we're good. Let me just look. There. That looks good. That looks end plate-ish. And that looks pretty good there. There's some fat around the root. Yeah. Let me just get that little guy right there. Yeah. Look at that. That's pretty cool. That's it. That's a nerve right there going across, down. It's called the traversing root. So you can see how far posterior we are here. Oh, look at that guy come out. Oh my, oh my. That is beautiful. That was sitting underneath the root. Okay, we just take the laser. Let me just see if I can flush this guy out. It's like a little sea anemone, just wants to sit there. All right, we're done.
We have another question.
Yeah.
One of our viewers is wondering, is this technically a microdiscectomy?
No, this is not a microdiscectomy. Scope off. This is not a microdiscectomy. A microdiscectomy is a 50-year-old, maybe 70-year-old surgery, and it involves removing the bones in the back of the spine, called a laminectomy. Okay? And then once you're done with the laminectomy, you're going to take part of the facet joint out. That's the bony joint in the back of the spine. And then once you're done with that, you move the nerve root over and you remove fragments of the herniated disc. It's a very different surgery than what we're doing. We're not opening the back up. A microdiscectomy is done in the middle. We went off to the side. A microdiscectomy takes the bone off in the middle of the spine. We don't do that. We're actually going around the side of the spine through a natural opening on the side. So there's no bone, there's no joint, there's no ligaments taken out like there is with a microdiscectomy. Microdiscectomy is a very damaging surgery. I don't recommend it for anyone. It should be abandoned and outlawed. Unfortunately, there are millions that are done every year around the world because the surgeons don't know how to do this type of surgery. All right, she's waking up. She's coughing a little. She's doing a little coughing. All right, let me show you the surgery was done right here through a tiny little incision. Little pressure. Great job, everyone. I'm going to come and answer questions. So start typing your questions up, and we'll just do a recap of the surgery. But I was very happy with the way the surgery went. Go ahead and type up your questions, and I'll even explain the difference between a microdiscectomy and what was done today when I get to the conference room.
All right, everyone, go ahead and type up your questions now. Dr. Deuk will be joining us for the post-op Q&A shortly, and we'll switch to his webcam view. If you look on the screen now, that is the MRI. The arrow is pointing to the disc that we just operated on, and below is a synopsis of the symptoms and what was done to repair it.
How's my hair look? Is it oh, hi. Yeah, Dr. Deuk here. So, we had a good question, and we're just wrapping up this Deuk laser disc repair, endoscopic transforaminal surgery that we did at L2-3, and I'm going to try to show you, first of all, what was going on with this patient that we just did surgery on, what made this patient's situation unique, different, and more difficult to deal with from a surgical standpoint. And then we're going to talk about the differences between what's called the microdiscectomy, perhaps the most common and popular surgical procedure done on people's backs around the world. It's been around for about 70 years, and the surgery is extremely barbaric and, in my opinion, should not be done anymore. Laminectomy, same thing. All right, let's start by talking about this particular patient, all right? And to really get into what's going on, I'm going to have to look at my side over there where the monitor is. So the disc is a cushion that is somewhat jelly-like, located between the vertebrae, and most specifically the part of the vertebrae called the vertebral bodies. So get a pretty good look at that, what the vertebral bodies look like. They are the main weight-bearing structure in the spine. About 85% of your weight goes down through the spine. It goes through the vertebral bodies. The other 15% goes through the posterior elements or facet joints. Okay? So if we were to take one of these discs out and look at it, this is pretty much what it looks like, okay? And the problems that we're fixing are located in the back of the disc where there's a tear and the jelly is pushed out. So in this patient's case, most disc herniations, as you can see here, they are a protrusion of the jelly backwards. And I mean just backwards, right there. That's like 99% of disc herniations, okay? And what I do is I come in, and I come in instead of through the direct back of the spine right here. I don't have to take any of this bone out to get to the disc herniation being there. What I do is I come around the side, which is over here. I come under the nerve root and I go straight into the herniation, okay? That's what the endoscopic surgery does. And that's the advantage of the endoscopic surgery. In a microdiscectomy, the surgeon comes here, peels the muscle off the spine in this area, and then you're left with this lamina right here, this piece of bone. You literally have to drill a hole in this bone. There is no natural hole like you see in the model. That doesn't exist. There's actually bone on bone. It's literally touching each other. So you got to make a huge hole in the bone, and while you're doing that, you're drilling part of this bone right here out. And that bone right there is the facet joint. And once you start drilling off the facet joint, it really weakens your spine tremendously. And that's why people who get microdiscectomies, they end up needing a fusion, because a surgeon took part of your facet joint out, took part of your bone out, took the ligament out, holding the bones together in here, just to get to the herniation, which is in the front there, okay? So by using the endoscopic approach, we're coming from the side of the spine. All right, we don't go translaminar like everyone else does in a microdiscectomy. We're going transforaminal, which is really off to the side. Okay, now, what made this patient's surgery so difficult is, you see the herniation right there? It didn't stay there. It actually shot backwards and then snuck up here, went up the spine, in the hole of the spine, pushing on the nerve root from the front of the nerve root, kind of sliding in that gap right there. Okay, that's called a migrated disc, and that's what this patient had, and that's what made the surgery so hard. And that's why I told her there's, a good chance I won't be able to get the herniation out because it's migrated so far north. So what I did was, instead of coming like I traditionally do straight in, I actually came from a lower entry point down here, and I angled up, and I got into the disc and I cleaned out the herniation, and that angle from bottom going up allowed me to sneak in to the front of the nerve root and clean out the herniation right in there. And I got all the way up to the pedicle, basically right up here. So that's what I did. I had to use a little pre-planning and, change my route that I normally take by starting lower and angling up, and that's how you address those discs that migrate upwards. Now, had the disc migrated downwards, I would have started higher and angled down. This is all extremely sophisticated, high level, like endoscopic spine surgery. This is as high level as it gets. There's not many spine surgeons in the world that can do migrated herniations that go up or down. We got lucky today and we got it done. So, but they're not common, thank God. Most of them are just straight backwards. All right, what other questions do we have, Sean?
So one of our viewers says, Dr. G, my husband has bone spurs and bulging discs all down his spine from his cervical to his lumbar. He's been to 3 doctors in Texas and he's still in horrible pain, but doesn't want a major surgery because he's seen what the fusion has done to me. It's permanently debilitated me. Could you help him?
Yeah, great question. So one of our viewers from Texas is talking about their spouse. And first of all, thank you for caring so much about your partner. That's wonderful to see. And he's very lucky to have you, okay? The answer is yes. This procedure can definitely help. Why do I know it can help? I know it can help because he sounds like he's having the kind of pain that comes from herniated discs, and that is what we fix with this endoscopic surgery. So my advice to you is pick an area of the spine that bothers him most, and let's get an MRI done, and then you can upload that MRI to our website at deukspine.com, and we'll do a free review for you. No charge, no obligation. I'll look at it myself. I'll figure out which discs are causing the pain. Sometimes I can't tell on the MRI alone. I need to do a video conference. So we offer a free Skype video conference, no charge. Again, we do this to help people all around the world, anyone that wants our help figuring out what's wrong and what can be done to fix it. So we call that a free MRI review and a free Skype, and we'll be happy to meet with you and your husband and figure out what needs to be done surgically to fix the problem. What we found, folks, is that there is nobody out there in back pain that can't be fixed, and I mean cured from their pain. What we've discovered is that there's a source to everyone's pain, and that source just needs to be properly identified, diagnosed, and then treated properly. And I will tell you this, some patients actually have more than one disc or more than one source to their back pain. So don't be surprised if you have 2 or 3 different causes of your back pain. A lot of times it starts with the herniated disc causing the pain, but people ignore it. They don't treat it properly. It doesn't go away, and they end up developing additional problems like piriformis syndrome or sacroiliitis, basically inflammation in other joints and areas of the back that also flare up and cause pain. So at that point, fixing the one cause of pain isn't going to fix everything, but we can fix everything. So don't be discouraged and don't feel like it can't be done. It can be done. It just needs the right diagnosis. That's really half the battle right there, the right diagnosis. I can't overemphasize how important that is. At Deuk Spine Institute, we can fix all types of pain in the back or neck. We just need to make the right diagnosis in order to fix it.
The viewer says, thank you, I'll get you his current MRIs.
We'd be happy to help. Are there
That was
any
our last
other
question.
questions? All right, that was our last question. We had a lot of really good audience participation today, and I hope you all learned a few things. We did 3 surgeries today. They were all broadcast live, unedited, and we answered questions during the broadcasts. We taught you a little bit about the difference between some of the more traditional surgeries and the endoscopic laser surgery that we're performing here at Deuk Spine Institute. So we'll be back again next Tuesday. For those of you who like watching the open surgeries, the big fusions, I have 2 big fusions coming up. Apparently one of them is a posterior cervical laminectomy and fusion. That's where I go in the back of someone's spine, in their neck, and I will cut all the bones out and open up, make room for the nerves and spinal cord. And then I'm going to be putting in what are called lateral mass screws, Lateral mass screws are screws that go into these little bones right here called the lateral masses. And I don't know what levels I'm doing, but I suspect it's going to be C3, C4, C5, C6, C7. And then also into the thoracic region where we're going to put in pedicle screws. So that's a very good surgery to watch. It takes an hour and a half. It's pretty graphic, and you get to see the spinal cord and nerves and everything. It's pretty cool. To date, we've done about 250 of those surgeries in our surgery center in the last 7.5 years, outpatient, all of them. We are the first in the world to be doing this surgery outpatient, and we probably are still the only ones that do it outpatient. Everyone else, the other surgeons, do these surgeries in the hospital, and the patients are usually there for a week or two. So we've learned to be able to do them and send people home an hour later, and they do fine. Okay, we've never had a complication or problem. On top of that, we're going to be doing as well, either next week or the week after, another open type surgery called the lumbar decompression and fusion. And today you saw me go from the side into the disc with the endoscope and laser, repairing the disc. It's called transforaminal, this being the neuroforamen right here, the foramen. So we're going trans across the foramen. Transforaminal endoscopic surgery is what we did today. Well, we're going to be doing a real, honest-to-goodness, multi-level, massive lumbar instrumented fusion with inner body cages that go into these spaces. And they look kind of like this right here, where you can see the cage. And I put those in through the back. But we'll be doing it across 5 levels. So basically the entire lumbar spine to the tailbone. So there should be some interesting surgeries coming up along with more laser surgeries. And bring your questions. I've enjoyed our time together.